My name is Laura Adang. I'm a child neurologist and physician scientist at the Children's Hospital of Philadelphia, and it's my pleasure to talk to you today about metachromatic leukodystrophy and our recent paper looking at the diagnostic delays we find in MLD using a novel real-world data approach. Metachromatic leukodystrophy, or MLD, is a genetic disorder in which children don't make sufficient amounts of a type of enzyme called aryl sulfatase A, or ARSA. When we don't make enough ARSA, then a toxic substrate called sulfatides begins to accumulate, and it damages our cells. In particular, the myelin, or the protective fatty wrapping that helps neurons to carry signals throughout the brain and the peripheral nervous system, is affected. And when the brain isn't able to carry signals and the peripheral nervous system can't carry signals, then children that had been developing normally begin to lose skills. Depending on the amount of residual ARSA that children have in their bodies, they may present very early within the first year of life or later, even sometimes in adulthood. And depending on when the symptoms begin and how much residual enzyme activity children have, they can be classified in one of four different subtypes: late infantile, early juvenile, late juvenile, and adult. And this paper focused on children with early onset disease who have the late infantile and early juvenile forms. So in this study, we focused on a real-world data approach. And by that, I mean we used two independent claims databases and a natural history study to understand better what happens before children get diagnosed with MLD. Because unfortunately, without newborn screening, almost all children are diagnosed too late. And so important information or clues on how the disease begins and affects children is really in that period prior to diagnosis. So a claims database is whenever we have any encounter in the medical system, it gets collated as a claims data point across a person. So depending on a natural history study, you may see multiple different doctors in different hospital systems, physical therapists in one place, physicians, or your neurologist is in another hospital. And we also oftentimes in the United States use multiple different sources of insurance. Sometimes you have private insurance, sometimes you have public insurance. And so the insurance claims get collated across a person. And so you can take this completely de-identified medical journey, and I can see every single time a child had a physical therapy encounter or a visit with a neurologist, and I can see how that neurologist coded that encounter, meaning there were concerns about language development, or maybe their pediatrician was worried about growth or failure to thrive. And so they use that billing code or ICD-10 code to mark each encounter. And so it's using those marked encounters, we can do that early mapping in a complete sense prior to diagnosis. I think the big minus of that is it's completely de-identified. I can't go back and verify that a child truly had that concern. I can just say that that's how that encounter was built, which is why we use two independent claims databases and also a natural history study in an attempt to bring increased rigor to a process that allows us to collect very large information at a very fine but potentially not accurate way. Right. And so that's why we used lots of ways to look at the same information. Claims databases are set up to allow us to be able to follow the same subject or person, regardless of where they get treatment or which insurance they have. And so it allows us, if a family changes jobs or moves states, you can still follow that individual. And if you anchor it to MLD diagnosis was made, you can then look back in the records. So while it took a long time and a lot of work from our team, this is exactly what claims databases research can do, which is track every single encounter once you have identified the subset of kids you wanted to follow. For example, in the main open claims database we present in the data set, there were 3.6 million records. 3,327 individuals had a single episode labeled as MLD, but then we decided to further narrow it down to when MLD was used as a claims code more than once and across a duration of time. Because let's say you have an MRI that's abnormal, or the family said, I'm worried about MLD, or someone had thought of it. You might label an encounter if it's having MLD, but the child didn't actually have it. And so we thought we could increase the rigor by making sure that MLD was used across multiple encounters across a longer period of time. And so we took that over 3,000 individuals in that large claims data set and narrowed it down to just 174 individuals for whom MLD was used more than once over a duration of time. Demographically, it matches what we would expect or anticipate the prevalence of MLD would be in the population of 3.6 million. And so it was starting to match up with what we expected to be real. What we found across the study is that really almost all children were diagnosed months to years after they started having symptoms of MLD. But the big challenge is that every child had a different medical journey. And there were many complications and repeated visits to various health services throughout their duration of life. So families kept on coming with multiple concerns, but they were pretty nonspecific, right? How many children have concerns with mild developmental delay or difficulty feeding, right? These are common concerns. And so it's really would be impossible for a pediatrician to have that needle in a haystack and identify of the thousands of patients that they see in a given month who have the concern of mild developmental issues or feeding issues. It's just hard, right? MLD has a very heterogeneous early prodromal symptoms. And it also emphasizes the fact we just need newborn screening. These signs and symptoms of MLD are presenting months to years before children are getting diagnosed. And to me, that's the big takeaway. There's not an easy way to find these children before they become symptomatic. And I would also push further that if a child is having signs and symptoms of MLD by developmental delay or eye movement abnormalities, or even feeding concerns, it makes me concerned that this inborn error of metabolism is already starting to affect their body. And I want to be able to deliver a treatment well before a child has problems or concerns. And so while potentially you could use these early signs and symptoms to pick up some additional children, in the end, what I really want is newborn screening. I want a child to not have to suffer from any of the signs and symptoms of MLD before we get them into treatment. And so to me, this is really underscores we are universally late in the diagnosis of MLD. It starts causing major disability in the body months to years before a child has neurologic decline. And we need newborn screening. That's really our only definitive path forward. We do have an approved treatment for MLD. It's a gene therapy, and we have both national US guidelines and international guidelines that talk about when we should be delivering the treatment. And the goal is for children to receive the treatment ideally within the first 6 months of life. And that's because we know there are these prodromal symptoms. And so, in order for a child to really benefit the most and have a potential curative treatment, we need to be able to get the treatment before they have the signs and symptoms. Some children, a subset of older onset disease, can still benefit to some degree from the gene therapy, but really for best outcomes, children should be treated as early as we possibly can.